Hi, everyone. Welcome to this edition of the CHP Spotlight interview series. This month, I'm really excited because we have Dr. Stephen Bernstein with us from Summit Orthopedics. I'm going to let Dr. Bernstein fill us more in about his background and what he does. But as a rough overview, he specializes with sports-related injuries involving a variety of different areas: shoulders, knees, ankles, particular interests in shoulder instability, ACL repairs, cartilage injuries, patellar instabilities, meniscal repairs, you name it. So Dr. Bernstein, thank you so much for joining us today.
Thank you very much for having me. I'm excited to be here.
Awesome. So first off, I know I summarized a little bit of that here, but I'd love to hear from your perspective a little bit more about what you do in regards to like the types of conditions that you treat and with the types of patients really that you typically help.
Yeah. So, well, first off, I am a sports medicine fellowship trained orthopedic surgeon in Chevy Chase. I'm part of Summit Orthopedics, which is it's a division of a larger group called Centers for Advanced Orthopedics. And in my particular division, there's 8 of us, and I'm one of 2 guys in our division that do predominantly sports medicine. So we're all somewhat subspecialized. And in my group, I treat predominantly acute and chronic injuries, fractures, overuse syndromes, acquired disorders involving predominantly knee and shoulder in athletes and weekend warriors of all ages.
Yeah, that's really helpful to hear. And I love that you finished off talking about like athletes and weekend warriors, because that sounds like I know where we've had a lot of overlap in our populations.
Yeah.
So with those, in regards to what you see, and with those weekend warrior types being like adults who are active, love exercising, caring about their health, and maybe those athletes, youth athletes, adult athletes, whatever the case may be, what are some of the more common injuries that you typically see?
So that's a big, broad question. But I talk to patients about this almost every day. I mean, there are really sort of 2 big, broad categories that pertain to both shoulder, knee, ankle, whatever the body part is, or the chief complaint of the patient. But there are these 2 big buckets of problems. And so one bucket, and I'll just use an example. One bucket is a tennis player comes in and says, I have right shoulder pain and it's been hurting me for about 6 weeks. There was no particular injury or event. It's starting to interfere with not only tennis, but my activities of daily living. It hurts when I reach into the refrigerator, but it's not markedly debilitating my function. So that's sort of one bucket. And that bucket is typical of an inflammatory overuse condition, as opposed to the same tennis player who says to me, I was in a heated match and I went to serve. I felt a pop in my shoulder. I had immediate pain. After that, I was not able to lift my arm. And since then, I've had marked dysfunction with regards to pain, ability to sleep, can't lift my arm. And so that really opens up the whole other bucket of more of a fracture, an injury, an internal derangement to the shoulder, as opposed to the first bucket, which is more sort of overuse and inflammatory.
Got it. No, I appreciate you mentioning that. So in regards to, let's say, some of those chronic overuse kind of injuries, so we see a lot of those. I know a lot of people watching this have a lot of those, and those are challenging, I know, in a lot of ways for people, because, right, it's not like there's one incident where something happened. It's kind of something that happens over time. So it's really hard to point to a cause and effect sort of thing. And so with those kinds of injuries, whether it could be pick your body part, shoulder, knee, ankle, whatever. What do you see as some of the most common things that contribute to that? And is there anything you wish maybe like the public knew to help mitigate that risk?
Yeah, I mean, so first in kids, you really see this with the subspecialization in sports. So kids now are not seasonal athletes. They are playing the same sport year round, whether that's tennis, lacrosse, swimming. And so that really leads into these overuse syndromes and overuse conditions. And so, and we see that in older athletes and weekend warriors as well. People typically like their sport and they want to play their sport 4 or 5 times a week. So I am constantly talking to patients about um, the benefit of cross training. So if you play tennis and you want to play 5 days a week, try to cut it back to 2 or 3. Incorporate yoga, Pilates, strength training, a spin class. Those things will complement your tennis and keep you out on the court longer. It'll improve your longevity. And it's sometimes hard for patients to hear. May not be what they want to hear, but I think that that's probably the single most important aspect to kind of allowing patients to play as long as they want to play. And that's really cross training, focusing on strength, core, flexibility, and doing other things other than the sport that they want to play the most.
That's a super smart perspective. It's funny, actually, with one of our patients, it reminds me, I had that conversation yesterday with a runner, very similar, because I almost see it as, and again, correct me if I'm wrong here, but I always see it as like you're stressing the body the same way over and over and over again without adding any like sort of variability in terms of the stresses you're applying to the system.
I'm sorry, you cut out for 1 second.
Oh, sorry about that, everybody. We're having some internet issues here this morning on my end. But what I was saying is, it reminds me of a runner that I saw yesterday where I was having this conversation with her, because, and again, correct me if I'm wrong here, but it seems like we're stressing the body the same way over and over and over again, and adding just not necessarily doing even less overall, just adding some variability in will change at least the stresses that our physiology is encountering. So I think that's a huge insight.
Yeah, it's funny because every year about this time is the Marine Corps Marathon. And so it's in October, and I will see a slew of patients who are ramping up for their marathon in end of September, sort of beginning of October. And these overuse issues, they're so common. At least a dozen patients around this sort of September, October time, while patients are just running in training for the marathon.
Oh, absolutely. Yeah, it makes a ton of sense. And it's so funny. Just like if we move through the same, for example, ranges of motion over and over and over again, naturally our bodies are going to adapt to make us more adept at that specific thing. But then of course you end up sacrificing some other qualities too as well. And that's really great to hear. And then so for somebody, actually, I'd love to hear from you in your field. Like these days, like, medicine, it's always one of those things, always changing, it's always evolving. In regards to your area, your sports medicine focused area of the on orthopedics, is there anything new and exciting going on these days, or whether it be new developments or anything like that the public should know about?
I mean, the technology, I've been in practice since 2000, and the technology over the past 24 years has changed unbelievably to make our lives much easier in the operating room. For example, when I was in training and we had to fix fractures, plates were straight. You had to bend them to shape the bone. It made cases complicated, and now that we have plates and screws that conform to different bone shapes, so that there are clavicle plates, there are proximal humerus plates, there are distal femoral plates, which have made life so much easier for us in the operating room. Also, a lot of what I do is reattaching tendon to bone, whether that be rotator cuff or in the knee. And so the advent of suture anchors and the technology regarding suture anchors. Initially, they came out as metal. So these were screw-like devices that went down into the bone. They had suture on them. The sutures wrapped through the tendon or tied on top of the tendon, which holds the tendon back down to the bone. But now most of these are biologic. They're bioabsorbable. They dissolve over time. And so the technology and the implants that we use have changed markedly. And then sort of the newest advent, which I'm having trouble getting started with, is, and I'm sure you're aware, there's platelet-rich plasma, there's stem cells, there's fat or adipose injections. None of these sort of biologic augmentations, which are being performed by a lot of providers, are FDA approved as of yet. But there is some early promising data, but not any long-term data for its use for rotator cuff repair augmentation or overuse injuries like tennis elbow or Achilles tendonitis or things like that. But that's a very, very up and coming area within musculoskeletal medicine, and a lot of providers have sort of jumped on this. I'm a little slower to do so, but my eyes are wide open, and I'm interested in it.
That's really interesting. That's so cool, and I appreciate you putting that into some perspective for us, because I've been seeing, I know myself, a lot of the regenerative medicine things that are out there, and it's always hard to know what stage of sort of the research process it is. So that's super helpful to hear. And based on all these new technologies or new approaches, new things that have been developed, research, what have you, I'm just curious. Do you feel like any of that contributes to why a lot of when we see these athletes on TV, why some of them are recovering from injury, like an ACL repair? Like I remember, I used to work in professional sports. Like I remember, okay, you have an ACL repair, like it's a minimum of a year that you're out before returning to the field. And now, like I remember, I think it started with Adrian Peterson, back in like, in some cases, like 9 months and even less. So I'm curious, do you feel like any of that is a contributing factor?
Yeah, so it's interesting. I mean, especially in the context of what's happening now with Aaron Rodgers and his Achilles tendon repair.
Yep.
But I think, ACL reconstruction, depending on the athlete, is anywhere between 6 and 12 months. And so, if you're a lower demand athlete who is not getting back into hardcore pivoting, cutting, jumping, twisting, 6 months may be a very reasonable timeline. If, however, you're going to go back to collegiate basketball, you really still are looking at 9 months, or in most cases, the season for that particular player. You're returning earlier than the season, but you're not going 100%, typically between 9 to 12 months. What's going on with Aaron Rodgers' Achilles tendon repair, I'm not sure we're getting the full story here. I do lots of Achilles tendon repair. I guess I do it the old-fashioned way. He had a very a minimally invasive subcutaneous repair, but the biology of tendon repair is the biology of tendon repair. I mean, I'm not sure how that really changes. And so, in my hands, the recovery from an Achilles tendon repair, I'm looking for single leg calf raises at 6 months, with return back to sports around that time. Again, it depends on the athlete, but to provide the push off strength required to play in the NFL, to get a patient back at, they're talking 13, 14 weeks. I'll believe it when I see it.
That you beat me to my next question, because I was going to ask that, and I'm baffled at the claims. Again, like you said, let's see it first. But yeah, that's that's so interesting. And then speaking of that, well, we got like an extra minute or two here.
Sure.
There have been a lot of conversations, because you see so many athletes about, and because this applies, I've gotten this question actually from parents of a lot of youth athletes. Do you feel that, like, because I know this happened with Aaron Rodgers, any of the playing surface was an influence there? I know it's hard to definitively make that claim, but I know at like the MetLife Stadium up in New York, there've been several different Achilles ruptures there now, or injuries. Do you feel like that is a factor in a lot of these issues?
Well, there is data to support that, especially for knee injury, that grass is safer than turf. And I think we're going to start seeing a slow transition back to natural grass. Achilles tendon injuries are a little bit different. They're sort of these eccentric loading. Basically, the tendon is elongating while it's firing. And I think that there's less data to support that a turf field it causes more Achilles injuries than a grass field. So in the case of Aaron Rodgers, I'm not sure that the field will.
Oh, there we go. We're back. Sorry about that. I lost you for one second. So only thing I want to say is you said you weren't sure that the field was necessarily the contributing factor.
For ankle Achilles, for Aaron Rodgers, but not necessarily. I think it is a factor, and there has been data to show a difference in incidence for the knee and knee associated injury. There's less give. There's less give in a turf field.
Gotcha. That's super interesting. It's good. I really appreciate you illuminating a bit about the Achilles stuff. It's funny now that I'm approaching 40 and still trying to play in my various flag football leagues and stuff. It's always something that now is being put in the back of my mind watching these professionals on Sunday. So, it makes me feel better too.
Patients ask all the time, is there something that I could have done to prevent this? When I see an acute Achilles tendon rupture, I'm not aware, nor is there any data that I know of that supports some kind of prevention program for Achilles tendon. ACL tears are different, but for Achilles, it's the 40-year-old basketball player, most typically. And it's unfortunate, but I don't think that there's any prevention for that.
It's good to have that clarity there. And you can always look at, it's funny, you can always look to like professional sports. Like if there was a way to prevent them, they'd be implementing it.
That's right. Yeah, it's a good point. Very good point.
Yeah. So I always got to see like, hey, what are they doing? Okay, maybe that'll trickle down to us at some point. So this has been awesome. I really appreciate these insights, Dr. Bernstein. And then most importantly, for people out there who are interested in contacting you, again, I can't speak highly enough of Dr. Bernstein, his colleagues at Summit Orthopedics. We've sent many patients their way, always have great experiences and get great results. But Dr. Bernstein, what is the best way for people to contact you, to reach you if they're interested in seeing you?
Yeah, I think through the Center of Advanced Orthopedics website, and we're the Summit division, or simply give us a call. Our office is in Chevy Chase. We also have an office in Foxhall, and that's not just for sports medicine; it's for all musculoskeletal needs. And I have partners that we pretty much cover all the bases. So
awesome. And then what I'll do for everybody watching this, I will link to their website below the video, so you have that information. And we've had patients scheduled there. It's very easy, not very hard, but. Most importantly, Dr. Bernstein, I really appreciate you joining us today, taking some time out of your busy schedule. So thanks again.
Thank you very much, Zach.